everybody. Thank you so much for having me here today. Sorry that we're not in person, but I look forward to next year when we are. We're going to be starting here today with cannabis and dementia. This is a fascinating topic for me, especially as the times have changed and we're seeing more and more dementia patients coming into the office and working alongside a dementia clinic to help patients. So, cannabis and dementia. The first thing I would like to introduce myself. My name is Dr. Sherry Yafai. I'm a physician in Los Angeles, California. I went to UCLA and got my neuroscience degree as an undergraduate back in 2001. I went to UC San Diego Medical School in 2005 and did emergency medicine training there until 2009. Since 2009, I've worked in the emergency department at Providence St. John's, as well as a number of other local hospitals. And during that period of time, in 2016, 2017, I pivoted my career and started working at the Relief Institute, where I am the medical director for cannabis-only medical treatment. It was around the same time that cannabis legalized recreationally in Los Angeles and in California, and we saw an uptick in the number of patients interested in using cannabis products for treatment. Since 2017, I have partnered up with Pacific Neuroscience Institute, a local organization that works with dementia patients as well as multiple other neurocognitive disorders and tumors. I've started working as a consultant for their dementia patients and started an educational series on patients with dementia. A few other notable references here. You'll see I work as an adjunct assistant professor at St. John's Cancer Institute since 2018, working and creating a chapter for the Merck Manual on cannabis. I have provided dementia educational research at Pacific Neuroscience Institute. We started just about 3 months ago, and we're looking forward to creating and expanding that treatment pathway for patients in 2022. Since 2018, I've sat as a board member of the Society of Cannabis Clinicians, which is a nonprofit medical education organization. And I served as the recent co-vice president with Dr. Janester Wilson-King. Since August of 2019, I've written a monthly column for Emergency Medicine News called The Case for Cannabis. And this is an article that I found was necessary in the medical literature, and especially in emergency medicine, where we were seeing cannabis constantly vilified and discussed in very just negative pathways, presenting the other case for cannabis. I sit on the advisory board for UC San Diego's International CMCR, as well as a previous director of research and development for high sobriety. A few quick disclosures. I am the founder and director of my own offices, the Relief Institute in Santa Monica and Los Angeles, California. I'm a board member of the Society of Cannabis Clinicians. This is an unpaid membership. I am the medical director for in-home infusions, a WowWee TV paid speaker, as well as a paid medical expert for cannabis legal cases here in California. Now, on to the topic at hand. Dementia and cannabis. And the big question most people ask me is why is this even important? Why are we looking into dementia? Well, in 2020, the Alzheimer's Association reported that 5.8 million Americans over the age of 65 were diagnosed with dementia and Alzheimer's. This is anticipated to grow over 2 times in the next 20 years. In fact, if you take a look at this graph, we see about 2.5 million, or 50% of the patients diagnosed with dementia and Alzheimer's are in the ages of 75 to 84. This is particularly important for the men out there in the audience, where we see an increased risk for men with age. Now, what do we see in terms of Alzheimer's disease? Alzheimer's disease is really a range of diagnoses. It starts with preclinical Alzheimer's disease and moves on to mild cognitive impairment, where the symptoms are mild and don't interfere with day-to-day activities, but patients start to notice that they're having changes in their memory. This can progress to mild, moderate, and severe Alzheimer's disease. And as those symptoms interfere more with our day-to-day activities, we require more caregivers. We have a larger ripple effect on the rest of our community, our family, and our loved ones. So much, in fact, that in 2021, the Journal of Alzheimer's Disease did a study on dementia, and not just dementia, but also the comorbid factor of insomnia. And here we take a look and see that the amount of money funded into healthcare and healthcare utilization is almost about 10,000 or third more in terms of patients with not just dementia, but dementia with insomnia. Now, I want to take a step laterally here for a moment. So if you take a look at the graph, on the right-hand side of the graph, you'll see non-insomnia dementia patients. Their healthcare costs in 2018 was close to $30,000 a year. This is really important because we see this healthcare burden over and over again, and the amount of cost going into it is expanding yearly. Now you'll take a look just to the left of that, the insomnia patients with dementia, the expenditure increases by roughly $10,000 or about a third of that cost. And this goes into increased outpatient visits, increased inpatient visits, and increased emergency department visits. This is where we're taking a look and saying, we need to do something a little bit better. So taking a further look into this particular study, they noted that insomnia and dementia was associated with three particular worsened outcomes. Number one being worsened clinical outcomes. Number two, increase in caregiver burden, which is a big cost and factor for all of my patients and their caregivers. Number three is increased healthcare costs. Again, this is about a third. And when you're looking at these larger numbers in the millions, this is an important factor. So how is it that dementia and insomnia, what is the big deal about this? Why are they getting worse clinical outcomes? Well, in this study in Alzheimer's dementia in 2021, it was found that insomnia severity is associated with worse global cognitive and memory performance. And this suggests that poor sleep might be particularly detrimental when the brain is already vulnerable to neurodegeneration. What does that mean? It means that patients who have dementia and Alzheimer's are more likely going to suffer more from this lack of sleep than most other aspects of their life. And in fact, in a recent lecture by Dr. Verna Porter here locally with the Pacific Neuroscience Institute, we noted that sleep was one of two main factors of what we can do for our brain health. So to prevent cognitive decline and dementia, making sure patients get good sleep on a routine basis is so valuable because we see that as a time when the brain can rehab and improve over time. All right, so then we go on to say, well, if insomnia is such a big problem for our dementia patients, what are we doing to treat it? What do we already have as solutions out there? And really, we just have two solutions, according to this article, again in 2021, in the Aging Disease Journal. And one of them is cognitive behavioral therapy, which is not easily accessible to everyone. In fact, I think this is unfortunately a very difficult to access treatment strategy, while very effective. And two is pharmacologic treatments, medications. And this is by far and away what you'll see most often for our older patients, as well as patients with stress, anxiety in their young ages as well. Most commonly, we're seeing hypnosedatives utilized for treatment strategies. And so, what's the big deal? If we can use a hypnosedative such as Ambien, Sonata, Lunesta, why not use that? Is there a problem to that? And in fact, we do. We see a problem. The problem is, and you'll see these are two separate articles documenting the same problem. I'm sure there's so much more, but that hypnosedatives are problematic for a variety of reasons. Number one, they show short-term effectiveness with problems of recurrence. How does that translate into clinic? Oftentimes what I'll see is patients showing up to the office after decades of using Ambien, Sonata, Lunesta, and they started at one dose and they continued to expand that dose over time. So it became one pill, it became two pills, it became wake up and take an extra pill. it becomes I'm taking a Ambien plus a Lunesta. It's I'm taking an Ambien plus a Benadryl to sleep, and I'm still sleeping poorly. So over time, these hypnosedatives are not effective. That's a big problem. Number two, it's ineffective with chronic use, which is what we were talking about. So it's effective short term, but long term, there's no, we lose out on those effects. And number three is adverse side effects. So patients are having cognitive impairment and falls. And in particular, in our discussion here today, the really important part is this cognitive impairment. So you see the article on the left in 2021, a review of insomnia patients treatments for patients with mild cognitive impairment showed an increase in Alzheimer's and dementia. And in 2017, we saw the same documented specifically with zolpidem or Ambien. So we're seeing increased risk of dementia in patients who are using hypnosedatives. Again, we're contributing to the problem that already is out there and is existing, and we're not helping fight that problem. Now, the other adverse side effect I included up here as a reminder is things like falls. Why is that important? Because my background in the emergency department, we routinely would see, I would call the bathroom the most dangerous place in the house. And the reason was patients will get up in the middle of the night to urinate, and they've got a medication on board that's sedating them. And so they fall, they get dizzy, they hit their heads in the bathroom, and they come in with head bleeds. Or they come in because they've now caused an injury, a fracture, a break, a broken hip, a broken shoulder, a broken arm. So these are the other side effects of these medications that we do see frequently. So what should we do? Is there, why are we all here today? We're here because we have this concept that potentially dementia and or insomnia can be helped by using cannabis. Now, is this something that we're just throwing out theoretically? No. In fact, there was an article, a review study in 2019, documenting about 6 different modes that cannabis can be helpful for our declining elderly patients. Number 1, treating agitation. This is important because what we're seeing is increased in agitation. This causes patients to fight with their caregivers, fight with their children, fight with people who are trying to help them, causing them to want to sedate them, add on other sedatives, and create a situation that can be problematic for the patient. Number 2, disinhibition, irritability, aberrant motor behavior, aberrant vocalization. And number 6, with limited evidence of improvement in rigidity and cognitive scores, as assessed by the mini mental state examination. This is the heart of our talk here today, that if we use cannabis to help with these other aspects of dementia, can we hurt or help our patients, right? Are we doing the same thing? Are we repeating the same mistakes of the hypnosedatives, or are we actually helping them? And what this article so adequately, appropriately stated is that we are seeing the beginnings of improvement in cognition scores. We are seeing improvement in cognition with the use of cannabis and not a decrease in memory, like we see with the hypnosedatives. So this is a nice visual where we can see this concept of a low dosage of cannabis in the aging population can give us about 4 different beneficial effects. 1, hippocampal neurogenesis. 2, to reduce inflammation in the brain. 3, to help with amyloid beta plaque clearance. And number 4, cholinesterase inhibition, to limit that, acetylcholinesterase inhibition. These are the parts that we're seeing in benefit with aging. Now, dosage matters. This is where I always say medicine is an art. It's not a perfect science. We're not doing engineering here. Not all people are made the same. And this is where we want to get into a bit more of those details. This is another article in the European Journal of Medicinal Chemistry in 2020 that shows the neuroprotective properties as it relates to CBD. And this was a particularly interesting article because oftentimes people ask me, well, do we know any of the data or science under how cannabis can be helpful and not hurtful in dementia and Alzheimer's? This is a lovely image of the presynaptic and postsynaptic cell where we see glutamate being released and its relation to both CBD as well as CB1 receptors. And this is where that neuroprotective thought process or that mechanism is coming from in terms of the utility of CBD in post-concussive, traumatic brain injury, and dementia. Specifically, in the case of neuron damage, CBD inhibits the release of glutamate to generate a protective response. To quote the article, CBD is expected to become an emerging treatment for Alzheimer's dementia. And CBD can rescue the production of neurofibrillary tangles. In addition, existing data indicate that CBD downregulates the level of caspase-3 and inhibits neuronal apoptosis. This is pretty dramatic information. This is pretty impressive, where in a disease process we don't completely understand how we can start healing and start helping and in fact stop the progression of dementia, which is really what we're seeing in the clinical presentations. So the secondary aspect, I like to think of cannabis in two different perspectives. One is daytime usage and one is nighttime usage. For me, when I speak to patients, oftentimes patients will hear me talk about the utilization of cannabinoids for daytime versus nighttime in order to separate out what's useful for being alert, awake, cognizant, keeping our memory intact, and things that help us become somnolent, help us go to sleep, help to turn off the lights upstairs without actually putting you out, right? We don't want to use a medication that actually knocks you out, right? We don't want to switch. We want a dimmer. Because what we see, or my hypothesis is here, is that things that will knock out your brain and put you out to sleep are also likely going to have long-term effects to that same idea, right? We're going to see those Alzheimer's and dementia potential peak up. All right, so going back to nighttime agitation in cannabis. In terms of nighttime agitation, we know that dementia patients have sundowning. We know the afternoons and evenings can sometimes be the hardest on caregivers as well as patients. When they become the most confused, they become physically agitated, they become verbally agitated, and sometimes physically and verbally abusive to their providers. So there was one study done back in 2006 on dronabinol, which is a synthetic THC at 2.5 milligrams, that showed a decrease in nighttime agitation with usage. And in clinical practice, we see very much the same. We see a decrease in hypnosedative use. We see a decrease in regular sedative use that can be offset with the utilization of a little bit of THC. So for those of you out there who are familiar with dosages, 2.5 milligrams in the state of California is considered half of a recreational dose, which is roughly 5 milligrams. So we're not getting patients high enough to get them having fun, but really just the goal here being to help them fall asleep. This study showed the following. It showed this nocturnal activity was decreased. So you'll see here, this is the number of nocturnal activity counts. This is at baseline where you see a larger amount of nocturnal activity. And then with treatment, the 2.5 milligrams of dronabinol or THC, that decreased pretty impressively across the board for patients. Now, this is important as we move on, that we'll see that each patient really needs their own personalized medication. And this is important because similar to something like blood pressure medication or thyroid medication, there's no one size shoe fits all, okay? We need to titrate these medications in order to get the best outcome from the patient. While 2.5 milligrams was a substantial or good enough dose for these, I believe it was a 2-week study, for this short-term study, oftentimes we'll see patients go one of two ways. Either after a period of time, they'll need an increase in dosage of THC, or they'll need a decrease in dose in THC. It is common as well for about a year or two to use the same dosage of THC with good outcomes. But again, this is not something that's going to stay the same for years and years. How about CBD and sleep? This is a question I get asked routinely because there's many claims on the internet. in the industry and individual reports where people say, oh, I take CBD and I go right to sleep. It's great. It's wonderful. Now, the first and foremost, excuse me, that's not written on the slide here is that when patients come to me and say, oh, I take CBD and I go to sleep, the first question I ask is, can you show me what you're actually taking? And this is really important because as a clinician who doesn't have access to a direct, doctor to pharmacy pathway so that we can ensure what our patients are getting, we really have to be very wary of what the patient is telling us they're getting, because they can get this on every street corner, online, sent out to them with checks and balances and sometimes without checks and balances. I've seen a number of them now at the local farmers market. And again, they're great products, but they're not necessarily what patients think they're being advertised to. So oftentimes when patients come in, they say they're taking a CBD product. What I look at the label and find is, no, this is in fact a partial CBD product and potentially even a THC dominant product. So to get back to the slide here, what you're going to see is the claims on the internet, the industry, the individual reports. These all aren't kind of aligning 100% together. And so the studies that are out there right now are the following. Number one, CBD is a wake-inducing compound that presumably activates neurons. In 2008, this study was done, and it was done, I believe, in mice models, taking a look at how CBD works. So that conflicts again with the idea that CBD is useful for sleep. Number two, CBD in rats enhances alertness and suppresses sleep. Patients oftentimes report back to me that CBD can feel like drinking like a cup of tea every day. It helps soothe their anxiety, but allows them to get on with their day better, or it helps their pain, allows them to get on with their day better. Number three, CBD and sleep. CBD decreased anxiety, but did not improve REM sleep in rats. This was a study done in 2012. And lastly, in 2018, no effects of CBD on the sleep-wake cycle of healthy subjects. And this was a randomized, double-blind, placebo-controlled crossover study. This was done in 26 healthy controls in adult patients, and they noted that they didn't change anything for them. Now, how is this different from what we're seeing on the internet, the industry, and the individual reports? I've talked already about THC being added to a number of these compounds, but oftentimes these compounds also have melatonin and magnesium in it. Melatonin and magnesium, individually of which can be helpful for sleep. So the question becomes, are those components overriding, or are those the dominant effects, or is it really CBD that's the dominant effects? About 1 in 10 patients will tell me that really CBD alone will help them sleep. And in fact, I find that to be true, but it's only about 10 to 20% that we're seeing this happen. So again, we're talking about individualized or personalized medical plans based on the patient and their responses. And the question becomes is, why is it that those individuals are doing well? And most of the time, what we're seeing is improvement in their anxiety that is keeping them awake, or pain that is also keeping them awake, both of which CBD has these great positive responses to. So, who brings dementia patients in, right? This is one that has come up over and over again. If patients are demented, how do they know to even come in and get, cannabis as a treatment strategy? Well, this is me and my husband talking about our parents, right? Hard to believe it's finally legal. That reminds me, your mother wants me to stop by and show her how to roll a joint. It's the adult children of dementia patients that are now bringing patients in for treatment. Oftentimes we'll also see spouses as well as caregivers bringing patients in for treatment. This is now become a whole family involved process to bring patients in for evaluation and treatment. So we're going to step a little bit sideways. We're going to pivot here a little bit and talk about blood flow and CBD, and where we're actually seeing some really promising new findings in terms of cannabis as a whole plant and CBD in particular in terms of improvement in cognitive disorders. So in this study, the effect of acute cannabidiol on cerebral blood flow and its relationship to memory. This was an MRI-based study where they found that CBD could cause a significant increase in regional cerebral blood flow to the hippocampus. These findings have great implications for use in CBD for disorders with hippocampal dysfunction, such as Alzheimer's disease, PTSD, and depression. This is huge because hippocampal, for those of you that don't know, the hippocampus is involved in memory, right? And part of what we've always been told about cannabis is that memory gets affected when we use THC, when we use cannabis products. And here we're starting to see the exact opposite in very real-time findings. And here's an image of the graph, an image pulled out from that study. And on the left-hand side, you'll see a cut of the brain on the MRI, and you'll see an increase. This is the placebo brain, and on the right, you'll see CBD with increases in blood flow in the hippocampal regions as compared to placebo. This is a really fascinating, phenomenal finding that we have not seen in a long time with any medication. And here you're going to see as well that we had immediate and delayed recall tasks that were improved, that did not improve with cannabidiol. That's the one aspect that did not improve. So recall tasks did not improve with CBD. So there's a question there. Why is that? Well, if hippocampus blood flow is improving, why is it that we're not seeing the recall task improving? But on the other hand, we are seeing an improvement, or at least no real change, in digit span task, back accuracy, and back reaction time. We're not seeing huge differences there. This study was done perhaps too soon in terms of looking at the longer term effects of the brain, as opposed to the short term effects on the blood flow. So that's one of the limitations of this study that hopefully they're going to go back and take a further look at in the future. Next, we see the potential and limits of cannabinoids in Alzheimer's disease therapy. So this is another study that, again, reviews all the priors, looking at the endocannabinoid system and the role in brain memory and cognitive function. We see this, that the ECS is involved in synaptic responsiveness and plasticity, that the high presence of CB1 in the hippocampus, again, the area where we form memories, and the cortex seems to be the main factor responsible for the psychotropic and the cognitive effects linked to cannabis use. Activation of CB1 and CB2 has revealed beneficial neuroprotective effects, reducing beta amyloid deposition and tau phosphorylation. Again, this is a repeat almost of what we saw in prior studies. It should also be noted that low doses of THC showed beneficial effects by inducing hippocampal neurogenesis and reducing amyloid beta plaque toxicities, or plaque deposition in rodents, as well as other dementia-related symptoms in both preclinical and clinical studies. Again, we're seeing less of this evil, THC versus the angel CBD being played out in a lot of these Alzheimer's studies. So we're starting to see that both of these, especially in conjunction with one another, may be beneficial in the long-term studies. So let's take a look at one more study here in terms of cognitive effects and THC. So remember, we're seeing improvement in cognition with these CBD studies. Can we also see improvement in cognition with the THC studies? And in fact, we can. And again, those two studies here, the Neurobiology of Aging in 2018, and then in Nature Medicine in 2017, where we're seeing the following. Extremely low doses of the cannabinoid drug THC reverse age-associated cognitive decline in old mice. Number two, the beneficial effects of a single dose of THC last for at least several weeks. Number three, THC elevates the level of sirtuin-1 in the hippocampus and prefrontal cortex of old mice. And number four, a single ultra-low dose of THC induces long-lasting structural changes in the brain of old mice that can be detected by MRI. So now we're starting to see these very structural changes in positive ways that are hopefully showing us long-term positive outcomes in dementia patients, according to the data and the science that's out there. So I did want to present one of my case presentations. We're going to flip over here in just a moment. But before I show you the video, I want to talk to you about her for a moment. And this is where we say the science is matching up with the clinical presentations and how that can come and have this really nice outcomes. So this was an 89-year-old female who presented to my office in 2019 with a history of anxiety, dementia, and insomnia. Her insomnia presented as frequent wake-ups, nocturia, and difficulty with sleep just in general. She had recently moved to Los Angeles from the Midwest to live with her daughter after a recent traumatic event. She had found her other daughter's body after her daughter had committed suicide. I mean, something that to me should never happen for any of us. This was probably the largest trauma in this woman's life. And she was having a really difficult time between the move, her underlying dementia, and the recent PTSD to coping with life. She was having anxiety that was leaving her caretakers frustrated. She was miserable on a day-to-day basis. I started her on a 4-part CBD to 1-part THC oil tincture with breakfast, and we added in a small amount of THC chocolate, 2.5 milligrams at bedtime. We found that this gave her better sleep, alleviated her anxiety, and allowed her to join group programs where she previously wasn't doing. 2 years later, in a recent follow-up, we found that she's doing much better, and not just much better, but we actually needed to wean her off of her daytime oils because her anxiety was at bay and she was starting to giggle a little bit excessively during the daytime. Now she remains only on the 2.5 milligrams of THC for sleep. And if you give me just a moment here, we're going to transition into the video. I think everyone, for sure, I enjoyed that. I'm sure all of you will also enjoy videos like that and seeing patients return to the office happy, healthy, mobile. Their caretakers are happier with their care. The children, the adult children are happier spending time with their adult parents because they're not being verbally lashed at, they're not being physically attacked, and they are just, in general, integrating so much better with their own lives. They're at peace with their own lives and not dealing with this chronic anxiety that they have no control over. She's been able to stay off of anxiety medications. She'd previously tried Ativan and it failed miserably for her. And she's just improved over time. And we don't see one of the things that is prevalent in dementia, which is a gradual decline in cognition almost predictably. She has avoided that and has done just so well. Okay, so is it really this easy? Are we going to see this outcome with all of our patients, this really positive, happy-go-lucky individual who's now integrated back into life again? No, it's not. In fact, it is really quite a challenge. And in fact, we'll see that challenge pop up in some studies. I wanted to present an oppositional study here because it's important to know what we're up against. This study was done in, I believe, 2015, and what it showed was there was no effect on daytime agitation with 0.75 milligrams of THC and 1.5 milligrams of THC in a twice-a-day dosing strategy. What does this mean? How does this all make sense? And as you'll see, and I'm going to assume every presentation that you'll hear today is the following, is that we really have to adjust these medications to the patient's needs. And small dosages, while they can be effective for some individuals, are not effective for all individuals. And we need to work alongside patients, caregivers, family members to adjust these dosages to that which helps them best. And what's helpful for today is not necessarily going to be the same medication that's going to be helpful 1 year from now. And that the brain is changing, and we are going to change to meet the needs of the patient as opposed to just writing them off and telling them to go out on their own and figure it out. This is a really important aspect of treating patients, in the medical field, where, again, this is an art. It is not a hard and fast science. One of the other downsides of studies such as this one is that they do not include CBD in the treatment strategy. And what they're trying to do is tackle a very big problem with just one chemical. And what we see time and time again in the world of cannabis is that CBD and THC and probably the other minor cannabinoids that exist out there are going to work better together, meaning we will eventually start seeing studies on CBG, CBDA, and THCA as they relate back to dementia and Alzheimer's. So we're gonna loosen up a little bit here and talk about just a couple other side notes as to how to treat patients. So you'll see here in this cartoon, a drug dispensary or a pharmacy will ask for your authorization from your HMO, your PCP, the IRS, and a marijuana dispensary, especially in areas where we see this as recreational, will act more like a fast food joint. Do you want fries with that, with your cannabis supersized version? And this is the challenge. The dispensaries right now are meeting the needs here in California and other recreational areas, are meeting the needs of the masses, which by far and away are younger recreational users. And so when we ask a 85-year-old patient to walk into a dispensary to get cannabis products for their 82-year-old spouse, it's hard to do. They can't do this on their own. This is not something they're used to. This is not the way medicine works in their mind, as it shouldn't, right? The person behind the counter, I'm finding more and more often, it changes on a month-to-month basis. This is not the reliable cannabis dispensaries of old here in California, where we could count on the same person being the bud tender for about 5 to 10 years. We're now seeing younger and younger individuals behind the counter who are interested in cannabis for their own recreational purposes and not for the medical or health purposes. The person behind the counter can only sell cannabis. They are no longer selling hemp products here in California. There's over 50,000 products available here in the state of California, and every time I turn around, they're changing. And so it's really important to be aware of the chemical components of all of these different product lines, as well as be familiar with your local product lines. The bud tender behind the counter is not a pharmacist. This is not somebody we're going to ask, despite my best recommendations. I tell them all the time, please do not ask your bud tender what to use for your medical diagnosis, because what the bud tender is not trained or not allowed to do is ask what other medications you're taking. So if you're also taking Ambien, gabapentin, and trazodone to go to sleep at night, they're not aware of that, and they don't know how to adjust your other medications in order to add in a cannabinoid tincture, oil, flower product. Overall, this is not cheap. Oftentimes, one of the big complaints of patients in my office is, why isn't this covered by Medicare? Why isn't this covered by health insurance? If this is helping me, why aren't we getting this covered by insurance? As compared to pharmaceutical medications that have a copay of anywhere from 50 cents to $5 for a month's worth of medication, you're looking roughly at anywhere from $20 to $150 for a month's worth of medication for dementia patients in particular. So where are our future studies? Where are we going to sit? Where are we going to move on from all of this? Do we have all the data we have or need? No, absolutely not. We have so much more to study. I work along, I work along with People Science. This is a new research organization where we're taking a look at what's actually available and working alongside cannabis companies to take a look at what they're actually offering or advertising. Is that really what's panning out? We've got an app where patients can download and respond about how their specific 3 products are going for these different sleep effects, right? So if we think that CBN and THC combined is going to be helpful for sleep, we want to actually see those results in real time. We don't want to do this in a lab. We don't want to do this with patients who are, only between the age of 21 to 30, because those aren't the patients that are realistically the only ones using these products. We want to test this on patients all the way up to 90, right? We want to be really aware of what's going out there in the world. So if you're interested in this, please reach out. You can also find it on www.peoplescience.health/sleep study, or you can email me, sherry@mdrelief.com. This is a new project. Sorry, that didn't come up so nicely on the slide there, but this is a new project we're working on with the local medical organizations. This is PNI, Pacific Neuroscience Institute, and Dementia Series, as I mentioned earlier, as well as Women's Health and Wellness Institute, where we find women are less likely to use cannabis products than men are on an experimental basis. They are more likely to seek the advice of their physician, and they are more likely to have more chronic health issues than men. So it's something that's really important and near and dear to my own heart to offer patients with breast cancer, patients with ovarian cancer who really desperately need these things earlier and sooner and at more advised paced processes. So this is an image of what the clinic should be looking like out in Santa Monica. You can see the sunset in the background. Hopefully we'll get some really good outcomes there, and I look forward to presenting some of those next year. So a couple other things in the news. UCLA Cannabis Initiative is actively enrolling in their rheumatoid arthritis study. This is using CBD, large dose CBD with Epidiolex in order to treat rheumatoid arthritis. If patients are interested, please by all means send them out to get evaluated and get enrolled in the study. I myself write an emergency medicine news column, as you can see on the right-hand side. If you're interested in offering something to patients or something in your waiting room for people to read, I suggest it. I suggest you have your colleagues read this, because this is really starting from A to Z of cannabis and why we should be looking at the other side of this medicine and not just cannabis hyperemesis syndrome, which is oftentimes the only thing in emergency medicine that we talk about. If you'd like to reach out to me, my name is Dr. Sherry Yafai. I work at the Relief Institute, as you mentioned earlier. My email is sherry@mdrelief.com. I look forward to meeting you all in person next year when coronavirus is a thing of the past, or at least a thing that we're all protected against. And we'll take some question and answer. I believe we're going to do that live in just a moment. Thank you so much again for having me here today.